a facial nerve palsy commonly can occur because of trauma as well. It can be a direct trauma, it can be because of surgical trauma when you're doing a mastoid surgery or a middle ear surgery. So, hello everyone, I am Dr. Vyshnavi, and today me and Riya together are going to discuss a very nice and interesting case of a patient who presented with deviation of face, and we are suspecting that this could be a patient with facial nerve palsy. Let's unfold this patient's case history and understand the symptoms, signs, how to arrive at a diagnosis, and I will be giving some insights at the end of the session on this topic as well. So, Dr. Riya, you can go ahead.
Thank you, ma'am. I'm presenting the case of Mrs. XYZ, a 50-year-old female, a housewife, resident of XYZ location, belonging to upper middle socio-economic status by modified Kuppuswamy scale. The date of examination was 22nd of December 2021. The history was given by the patient herself and seems to be reliable. The patient presented to us with the chief complaints of deviation of angle of mouth to the left for the past 5 days and loss of complete closure of right eye for the past 4 days.
Okay, so are these the only two primary complaints, or the patient has experienced other symptoms also, like watering from the eyes or dryness from the eyes, or decreased hearing or increased hearing, loss of taste sensation? Any specific complaints that you have inquired and found out, or only these complaints are the complaints experienced by the patient currently?
Ma'am, these are the complaints that the patient had the most problem with, but on eliciting history, the patient also complained of watering from the eye.
Okay, so here the patient is mainly complaining to you of deviation of the angle of mouth that has been there since 5 days. So basically the patient is having certain asymmetry in the face, which is why the patient is most concerned about. Even if there are other symptoms, I'm sure that the patient would be less vigilant about it, because the patient is currently most concerned about this cosmetic deformity that the patient is experiencing in the form of deviation of the angle of mouth, deviation of the face, etc. Yes, so can you tell me more about these complaints, what the patient has experienced?
History of presenting illness. The patient noticed slight deviation of her angle of mouth to the left side for the past 5 days, due to which there was drooling of saliva from the angle of the mouth. The patient also had complaints of inability to close completely her right eye, which was associated with dryness and grittiness sensation in her eyes.
Okay, so basically the patient is having deviation of the angle of mouth to the left side, and there has been drooling also from that side, and there is incomplete closure of the right eye. Now, when we are having this asymmetry of the face or a facial deformity like this that the patient is presenting to you with, what is the obvious thing that strikes your brain?
And that this is a case of facial nerve involvement.
Correct. Now, when you think about a patient with facial nerve involvement, now you see the symptoms are on two different sides. The deviation is towards the left side, where the eye closure is not complete on the right side. So, which side facial nerve palsy is this? Is this a right facial palsy, or is this a left facial palsy?
Seems to be a case of right-sided facial nerve involvement, as there is inability to completely close the eye on the right side. The deviation is occurring towards the left side because of the normal functioning muscle of the left side is pulling the angle of the mouth towards that side.
Correct. So, since we are thinking of the facial nerve involvement over here, we are assuming that there is a right-sided facial palsy, because of which the right-sided facial muscles have become weak. Since the right side muscles are weak, there is obvious pulling of the angle of mouth towards the opposite side, where you have got stronger muscles causing this deformity, where there is a deviation of the mouth. Now, the patient is also having incomplete closure of the right eye, which indicates that the right side orbicularis oculi, which is supplied by the facial nerve, is paralyzed, because of which the patient cannot close his eyelid. Even the levator palpebrae superioris is also supplied. So, mainly because of the palsy of the facial nerve on the right side, the patient is having incomplete closure, and the deviation is towards the left side because of stronger muscle pull on the left side. So, clearly when we know the symptom is of a deviation of angle of mouth and incomplete closure of eye, we are sure that this is a patient in whom there is a facial nerve involvement. Now, we know that this is a patient in whom there is a facial nerve involvement. What are the leading questions that you'd like to put forward with this patient?
Ma'am, I would like to ask, as the facial nerve involvement could be because of multiple causes, so I would like to ask for the other symptoms, such as if there is any other feature of CNS involvement. For example, I should ask the involvement of any other cranial nerve, such as blurring of vision or double vision, or any auditory complaints, as also any change in voice or loss of taste. Also, other motor and sensory symptoms are relevant, so I would ask for weakness of limbs or any difficulty in walking. I would also ask for sensory sensations over the face as well as over the body. Then other cerebellar symptoms like imbalance, falling towards one side, ataxia, walking or gait abnormalities. Then I would ask, as the seventh nerve courses through the temporal bone and has relation with the middle ear, so I would ask for any ear pain or ear discharge or any fullness of the ear or reduced hearing. And also ear vesicles, as in Ramsay-Hunt syndrome we can also find involvement of facial nerve. Also, facial nerve could be affected if there were any recent viral or upper respiratory tract infection, or can involve the inner ear because of the viral infection. History of trauma, as temporal bone fracture, could also involve the facial nerve.
Yes, so basically when we are trying to elicit a history in a patient who has presented with an acute onset of deviation of the angle of mouth, suggesting us that there is a facial paralysis, we need to ask a history that is relevant to identify all the causes of facial nerve paralysis. Now, the facial nerve paralysis can happen because of various causes. It can be because of viral infection, it can be traumatic, it can be idiopathic where we see in Bell's palsy, it can be following any infections of the facial nerve, it can be because of any middle ear or temporal bone diseases like a CSOM or an ASOM that is affecting the facial nerve. There can be involvement of the facial nerve because of tumors like an acoustic neuroma or a facial nerve schwannoma or a meningioma or any cerebellopontine angle tumor or any vascular condition. So any kind of causes that can involve the facial nerve, you must take a detailed history asking that. So in a patient with facial nerve palsy, it is very important to take a detailed history to identify the cause of the facial nerve palsy. And when you do not know what is the cause, now you've asked all this history, any reduced sensation, any weakness indicating any cortical lesions, you have asked any ataxia or gait abnormality indicating any cerebellopontine lesions, you have asked about eighth nerve involvement in terms of hearing loss or any imbalance which is not there, you have asked for any middle ear problems which is not there, you have asked for any other parotid abnormality, swelling in this region, there is no such lesion. So when everything is negative, then you go to a diagnosis which is idiopathic facial palsy, and idiopathic facial palsy is called as Bell's palsy when you have ruled out all the causes on the basis of history and on the basis of investigation. So you have taken an adequate history, you have done a clinical examination and you have investigated a patient, and after having done all this and ruling out all the possible causes, then you are labeling the patient as Bell's palsy. This is why it is very important to take a thorough history in a patient with Bell's palsy or a facial nerve palsy. Here we are not labeling that the patient is having Bell's palsy. We are only trying to exclude the other possible causes of facial nerve palsy. So she has asked about all the important causes, but what Riya has missed here is about any loss of taste sensation, any decreased lacrimation or dryness in the eye, which she just mentioned in the history of presenting illness. She has missed about any decreased salivation, because facial nerve also gives secretomotor fibers to the submandibular and sublingual salivary gland. So if there is a dry mouth, decreased watering or difficulty in chewing the food because there is no saliva, so these other symptoms must be asked for the patient.
The past history. The patient has no history of any similar complaints in the past. The patient is a known case of type 2 diabetes mellitus and hypertension since the past 2 years and is on regular medication. The patient is not a known case of tuberculosis, asthma or any seizure disorder.
Why is it important to know the status of diabetes mellitus in a patient with facial nerve palsy?
Ma'am, diabetes mellitus could be a systemic cause of causing a facial nerve palsy.
Yes. So when we talk about Bell's palsy, there is a 2 times higher risk of association of Bell's palsy in those who are diabetics. So diabetes pregnancy, herpes zoster infection, these increase the risk of a person to develop facial palsy or Bell's palsy. So if the patient is diabetic, if you do not know any other cause, then diabetes itself could be a risk factor for the patient to develop facial nerve palsy.
Family history. There are no history of similar complaints in the family. There is no history of type 2 diabetes mellitus, hypertension, asthma, seizure disorder in the family. Personal history. The patient consumes a vegetarian diet. She has a normal appetite and normal bowel and bladder habits. She takes an adequate sleep. Treatment history. She is taking regular medication for diabetes and hypertension. Tablet glimepiride 1 mg once a day and tablet telmisartan 20 mg once a day.
What is glimepiride?
And glimepiride is a sulfonylurea group of drug.
It is used for the treatment of what condition?
It is used for the treatment of diabetes mellitus.
Yes, so whenever you are mentioning in the drug history, you must mention about the, not the brand name, but about the composition of the drug, because you need the generic form of the drug when you're talking to your examiner and not the brand name of the drug. So, you're using this glimepiride and telmisartan for treatment of diabetes mellitus and hypertension respectively. Okay.
On examination, general physical examination, the examination was done in a well-lit room after taking due verbal consent from the patient. The patient is conscious, cooperative, and well-oriented to time, place, and person. Vitals of the patient are as follows. The blood pressure is 130 by 76 millimeters of mercury in right arm in supine posture. The pulse rate is 80 beats per minute, regular in rhythm, normal in volume and character. The vessel wall is not palpable. Normal peripheral pulses bilaterally were felt with no radioradial or radiofemoral delay. On head-to-toe examination, no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema was there. On deviation of angle of mouth to the left could be appreciated. There was loss of nasolabial fold over the right. There were no vesicles or skin lesion present over the face or the ear or in the throat. On ear examination, there were no lesions over the pinna or the external auditory canal. The tympanic membrane appeared to be normal with the cone of light visualized.
Okay. So when you mention about a head-to-toe examination, I am specifically interested to know about any other positive finding other than deviation of the angle of mouth and loss of nasolabial fold. Did the patient have any other positive finding, or was everything else normal in this patient?
Ma'am, there was no other positive finding.
Okay, so when you did a facial examination or when you examined the face of the patient, did you see that the forehead had equal wrinkling, or it was an asymmetric sparing of the forehead was seen?
No, ma'am, there was no, the forehead was not spared. There was decreased wrinkling over the right side.
Okay, so when you see that the forehead is spared on one side, what do you think is the lesion? Is this a UMN lesion or an LMN? Upper motor neuron lesion or a lower motor neuron lesion?
In a lower motor neuron lesion, the forehead is not spared, whereas in a upper motor neuron lesion, the forehead is spared.
Okay, so let me explain to you what is the difference between an upper motor neuron facial nerve paralysis versus a lower motor neuron facial nerve paralysis. So if there is any pathology above the facial nerve nucleus, then we call it as an UMN pathology, and if there is a pathology at the level of facial nerve nucleus and below, we call it as an LMN facial nerve paralysis. Now, facial nerve nucleus is present in the pons, which is in the brainstem. Now, this facial nerve nucleus gets innervated from the higher cortical center. Now, this facial nerve nucleus has two parts, a ventral part and a dorsal part. The ventral part or the upper part of the facial nerve nucleus receives bilateral innervation, meaning it receives from the right-sided cortex as well as the left-sided cortex. Similarly, the left-sided facial nerve nucleus, the ventral part receives innervation from the right side as well as left side. So, the ventral part of both the sides facial nerve nucleus gets innervation from both the sides. So, there is a bilateral innervation, but the lower part of the facial nerve nucleus, which is the dorsal parts, receives only unilateral innervation, only from the respective side. It is not from the opposite side. So, what is the importance of this? The ventral part of the facial nerve nucleus is responsible for supplying your forehead or the upper part of your face. The dorsal part or the lower part of the facial nerve nucleus is responsible for supplying the lower part of the face. So when we talk about a UMN lesion, a upper motor neuron lesion, which is above the level of the facial nerve nucleus, indicating a cortex lesion, even if one-sided cerebral cortex is involved, what will happen? On that side, the facial nerve nucleus is affected. But since it's receiving bilateral innervation from other side, it is still able to function. But what happens to the dorsal part? It is receiving innervation only from one side. It is not receiving from both the sides. So the dorsal part will not function because the innervation to the dorsal part of facial nerve nucleus is affected. So now this patient will have sparing of the forehead. Sparing of the forehead means since the ventral part is still functioning, the patient is able to raise his eyebrows, and you will also see the wrinkling of the forehead. So even if there is a involvement of the upper motor neuron, the patient is not developing the palsy on the upper side because of bilateral innervation. But because the dorsal part receives only unilateral innervation, there will be a facial palsy on that side. So forehead is involved only if there is a bilateral UMN palsy. Otherwise, forehead is spared. In LMN palsy, in LMN palsy, definitely the patient will have involvement of the lower part of the face, where there will be deviation of angle of mouth, there will be drooling of saliva, there will be loss of nasolabial fold, there will be weakness of the orbicularis oris and the orbicularis oculi muscles, there will be hyperacusis because of palsy of nerve to stapedius. The patient will have decreased watering from the eyes because of loss of sensation, loss of supply from the greater superficial petrosal nerve. The patient will have loss of taste sensation because of the involvement of chorda tympani nerve. So basic difference of a UMN versus LMN all lies in the forehead. So if the forehead is spared, then it indicates that it is a UMN palsy. It is not a UMN palsy, it is an LMN palsy because the ventral part receives bilateral innervation. Yes, so whenever there is a UMN lesion, the forehead is not involved, it is spared completely. So we have understood why it is important to look for forehead and the facial deformities in your head-to-toe examination, because that entirely rests your diagnosis onto.
Yes, ma'am.
Now you have mentioned about the ear examination, which is essentially normal. You do not see anything in the external ear tympanic membrane, and you see the cone of light, which indicates that there is no external ear or middle ear pathology. Now the facial nerve takes a course right from the pons till the periphery, dividing into 5 terminal branches. So the lesion could be present anywhere. So your examination has to be perfect for you to identify exactly where is the lesion in the facial nerve. So let me see how you have proceeded in your examination.
On nose and throat examination, no apparent abnormalities were detected.
Okay.
Nervous system examination, higher mental functions. The patient is conscious, alert, cooperative, oriented to time, place and person. The patient's immediate, recent and remote memory seems to be intact. The patient does not show any speech or language abnormalities, and the lobar functions appear to be normal.
So here you are assessing the higher mental functions to assess if there are any cortical lesions that are not supplying effectively to the facial nerve nucleus, which could be a possible cause of facial nerve palsy. So here everything is normal. So you are probably ruling out a cortical lesion that is responsible for causing a facial nerve palsy.
Proceeding with the cranial nerve examination, the functions of first cranial nerve appears to be normal bilaterally. The visual acuity bilaterally was counting finger at 6 meters. The visual field was normal by confrontation. There was no visual inattention or sensory extinction. The pupil was round, regular and reactive. The color vision appeared to be normal bilaterally. On third, fourth and sixth nerve examination, there was normal ocular motility present in all directions bilaterally, and direct and indirect reflexes could be elicited in both the eyes. On fifth nerve examination, both sensory and motor were intact bilaterally, and the jaw jerk was absent. On seventh nerve examination, on the left side, deviation of angle of mouth was appreciable. On the right side, loss of nasolabial fold, loss of forehead wrinkling, and inability to raise the eyebrow could be seen. The patient had difficulty in chewing and puffing a puff of air. Bell's phenomena was appreciated on the right side, and the taste sensations were found to be normal. On 8th nerve examination, it was normal by ticking watch test bilaterally. On 9th and 10th nerve examination, palatal movements were present and equal bilaterally.
Okay, so you have mentioned about something called as Bell's phenomenon. So can you tell me what is the meaning of a Bell's phenomenon?
Ma'am, Bell's phenomenon is a synkinetic movement that when a person closes their eyes by the action of orbicularis oculi, our eyes uproll and move outwards and uproll so as to protect if the eye is opened from the external influence. So in a patient where there is a loss of facial nerve with the action on the right side, this would be more appreciable because of the synkinetic movement, as the orbicularis oculi is not acting, the synkinetic movement of uprolling of eye and outward movement is more appreciable.
Yes, so Bell's phenomenon is typically seen in a patient with facial nerve palsy, where you can clearly appreciate that when you ask the patient to close the eye, or when a forcible movement is done to close the eye rolls upwards and outwards. So here what is happening is the afferent for this reflex is carried via the facial nerve, while the efferent is via the third nerve. So the involvement of the oculomotor nerve causes movement of the extraocular muscle, especially the superior oblique, which pulls the eye in the upward and outward direction. So this rolling of the eye is called as Bell's phenomenon, and this Bell's phenomenon, like you said, is a synkinetic response, and this indicates that there is a facial nerve palsy on that particular side. Okay, so you have told about loss of nasolabial fold, loss of wrinkling, inability to raise the eyebrow, but you haven't told me as per the facial nerve grading that we have for the facial nerve, which is called as the House-Brackman grading. In which category does the patient fall? Does the patient fall into grade 1, grade 2, grade 3, grade 4, grade 5 and grade 6? Let me explain to you the gradings first so that you can decide on which grade does the patient fall onto. So grade 1 is completely normal. So I am just simplifying this grading so that it is easier for you to remember and understand, although there are number of terminologies that are used in the grading class system. So 1 to 6 is the grading system. 1 is absolutely normal, which is me, you and everyone else who do not have a facial nerve palsy. And 6 is complete paralysis, where you have a mask-like face where there is no movement at all. That is grade 6. So 1 and 6 are over. So now you are left with 2, 3, 4 and 5. So 2 you can remember comes closer towards the normal, and 5 comes closer towards 6, which is the complete paralysis. So 2 is mild, 3 is moderate, 4 is moderately severe and 5 is severe. So how do we say mild, moderate, severe, moderately severe? So mild is they more or less look normal. Even at rest, there is no deviation or asymmetry of the face. There is complete closure of the eye with minimal effort. There is no synkinesis or any mass movements. So typically this is sufficient for us to know that there is a mild facial palsy which is elicited only on specific movements that you ask the patient to do, like say smile or blow the cheek or close the eyes. So only on close observation you can visualize this. So that is grade 2 or mild. 3 is moderate. So in moderate, the patient is able to close the eye completely, but it is with maximal effort. It is not with minimal effort, but it is with maximal effort that the patient has to close, but it is still closed. There are mild synkinetic movements, but there is no mass movements or large synkinetic movements. And here, even at rest, you can see that there is a mild asymmetry of the face. That is grade 3. Which I have told you is moderate facial nerve palsy. 4 and 5. 4 is somewhere between mild and severe. So here the patient is having definite asymmetry of face at rest, incomplete eye closure despite maximal effort. There is also synkinetic or mass movement. And grade 5 is almost like a complete facial nerve palsy. Here there will be no closure of the eye even with complete effort, there will be obvious deviation that you can see, and there will be barely any perceptible motion of the facial muscles that you will see. And in grade 6, there is a complete absence or a mask-like face. So synkinesis is seen in 3 and 4. In 5 and 6, you do not see this synkinesis. There is barely perceptible movement in 5, and in 6, you see a mask-like face. So now that you know the 6 grades of House-Brackman classification, where do you think is this patient fitting?
Ma'am, this patient is most likely a grade 4.
How do you say it's grade 4?
The patient has a deformity, appreciable deformity at rest, so it could not be grade 1 or grade 2. Second of all, as the patient has the patient is unable to close the eyes even with maximal effort, so it is not grade 3. And further, there is no absence of synkinetic movements which are to be present in grade 3 and grade 4. And here Bell's phenomenon is appreciable, which is a synkinetic movement. So it cannot be grade 3, so it's most likely a grade 4.
Yes. So sometimes there can be overlap of findings, so we can say House-Brackman grade 3 or maybe grade 4. But here, since you are telling me typically that the eye closure is incomplete even with maximal effort, there is obvious deviation even at rest, there are synkinetic movements, then it indicates to you that this is probably a patient with grade 4 House-Brackman facial nerve palsy. Now you have mentioned that the taste sensation is normal. So if the taste sensation is normal, where do you think is the lesion in the facial nerve? Above the level of the branch of the chorda tympani or below the level of the branch of chorda tympani?
After the facial nerve has given out the branch of chorda tympani, then the lesion is present.
Yes. So here typically, since the taste is normal, it essentially means that until the chorda tympani nerve, the nerve is functioning well. Beyond that, probably there is a lesion, which is why the patient is having facial nerve palsy, and the chorda tympani is giving you the diagnosis that here probably the lesion is not anywhere in the course of the facial nerve from the pons to the inner ear to the middle ear to the mastoid and exit. So up till the level of vertical segment of the facial nerve, we know it is working well because you said chorda tympani is functional. Now we have to look for causes beyond the chorda tympani, which could be at the level of stylomastoid foramen, which could be at the level of parotid, or which could be after the exit from the parotid. So now our brain is looking towards lesion or site where the facial nerve is involved. So we know that the facial nerve traverses commonly with the 8th nerve. They both of them travel from the pons through the cerebellopontine angle into the internal auditory meatus. From the internal auditory meatus, the 8th nerve supplies the cochlea and the vestibular component, which is the utricle saccule and the semicircular canal. The facial nerve crosses the inner ear, goes to the middle ear and continues from the middle ear to the mastoid, and from the mastoid it exits at the stylomastoid foramen, enters the parotid gland, and after exiting from the parotid gland it gives rise to 5 terminal branches. So since we know the facial nerve has a very long course, anywhere in the course you could have a cause that could be interrupting with the neural conduction to result in a facial nerve palsy. Now, to identify whether the cause is at the level of pons or at the level of cerebellopontine angle or at the level of internal auditory meatus, you are doing this cranial nerve examination. Now, if it were a cerebellopontine lesion, it could involve the 9th, 10th and 11th nerve also. If it were an internal auditory meatal lesion, it could involve the 8th nerve also, which we do not have in this particular patient, which will help us identify that the lesion is probably not located there and the lesion is located somewhere in the middle ear, mastoid or elsewhere below. Now, you know that the taste is normal, so you are ruling out any lesion in the middle ear and mastoid, and you are focusing probably after the facial nerve has exited from the stylomastoid foramen, that you are thinking that there is a probable cause of the facial nerve palsy.
On motor system examination was done so as to rule out any central cause for the facial nerve involvement, but all the parameters including tone, power, reflexes came out to be normal. Similarly, on sensory system examination, no deficit was appreciable. On sensory system examination, sensory loss near the concha on the right side could be appreciable. Rest other than that, all sensations were intact bilaterally. No positive findings were seen on cerebellar system of examination. There were no signs of meningeal irritation. The skull and spine appeared to be normal and the gait of the patient appeared to be normal. Cardiovascular examination. The S1, S2 was heard normally with a normal S2 split and no added sounds and murmurs were heard. On respiratory system examination, The chest movements were equal bilaterally and normal vesicular breath sounds were heard in all the areas. On per abdomen examination, a soft non-tender abdomen was palpable and no palpable organomegaly was present. Based on the history and examination, my patient which having low deviation of angle of mouth towards the left side and loss of nasolabial fold, loss of wrinkling of the forehead, inability to close the eyes on the right side is most likely a case of lower motor neuron infranuclear facial palsy with no CNS involvement.
So you mentioned that this is a lower motor neuron palsy. So do you say that this is a peripheral facial palsy or a central facial palsy?
Ma'am, it's a peripheral facial palsy.
What is the definition of peripheral and what's the definition of central facial palsy? So can you define what is the difference between a central facial nerve palsy and a peripheral facial nerve palsy?
Ma'am, a central facial nerve palsy involves all the causes which are present, which involves above the facial nerve nucleus, whereas a peripheral facial nerve palsy refers to the involvement of the facial nerve nucleus itself or lower down the course of facial nerve.
Okay, so can you tell me the course of the facial nerve in brief? How would you divide the course of the facial nerve?
Ma'am, the facial nerve originates from the facial nerve nucleus in the pons, and its course could be divided majorly into three parts. One is intracranial, the other is intratemporal, and then the last is extracranial. So after originating from the pons, the facial nerve traverses from the pons to the internal acoustic meatus comprising of the intracranial part. From the internal acoustic meatus to the stylomastoid foramen, the facial nerve courses through the intertemporal region, which is further divided into four parts. One is intrameatal, the other is labyrinthine, the third is tympanic, and the fourth is the vertical segment, which exits the stylomastoid foramen. From the stylomastoid foramen, the extracranial course begins, from where the cranial nerve traverses towards the parotid gland, divides into an upper and an anterior and posterior division, and further gives 5 end motor branches, which is zygomaticotemporal, frontal, zygomaticotemporal, upper buccal, lower buccal, mandibular, and cervical.
Okay, so you told it correctly. But it's not the frontal branch, but it is the temporal branch of the facial nerve. Except the one branch in the peripheral branches, everything else that you have described was absolutely right. Now, can you tell me which is the longest segment of the facial nerve? Is it the intracranial, intratemporal, or the extracranial?
And the intratemporal part is the longest part.
Which is the shortest segment in the entire course of the facial nerve? Whether it is intracranial or in the intratemporal, we have learned labyrinthine, we have learned about tympanic, we have learned about the mastoid, we have learned about the meatal. So, which is the shortest segment amongst all these? Okay, so can you tell me amongst the all segments that we have, intracranial, intratemporal, extracranial, in the intratemporal we have 4 parts: meatal, labyrinthine, tympanic, and mastoid. Which is the shortest segment?
And the labyrinthine segment is the shortest segment.
Okay, so the labyrinthine segment is the shortest segment and it is prone for ischemia and edema most commonly. So whenever there is an edema that is compressing on the facial nerve, the first segment to be involved is the labyrinthine segment of the facial nerve. Now this labyrinthine segment of the facial nerve traverses from the inner ear and goes to the middle ear. Okay, so can you tell me what is the landmark for the first genu of the facial nerve when it transitions from the labyrinthine segment to the tympanic segment?
Ma'am, the first genu, which is marked by the landmark of processus cochlear-fumus on the medial wall of the middle ear.
Now, when it goes from the medial wall to the posterior wall, it makes a second turn, which is called as the second genu. So, can you tell me what is the landmark for the second genu of the facial nerve?
Ma'am, the pyramid.
Yes. So, in the medial wall of the middle ear, the nerve runs horizontally, which is why it is also called as horizontal segment of the facial nerve. This horizontal segment of the facial nerve lies above a window, which is called as the oval window, and lies below a canal, which is called as the lateral semicircular canal. After that, it exits from the vertical segment or the mastoid segment through the foramen called as stylomastoid foramen. From there, like you told, it enters the parotid gland, and after it exits the parotid gland, it gives rise to 5 terminal branches. Now, what do you think is the cause in your patient to have the facial nerve palsy? We have learned the entire course, we have revised the entire course. Now, we need to know where exactly is the pathology and what is the cause of this pathology.
Ma'am, as the taste sensations were intact, so the pathology is most likely after the chorda tympani branch had been given. So the facial nerve gives the chorda tympani nerve when it is traversing through the posterior wall of the middle ear, that is the vertical segment. Either the pathology is after that region, after that segment, which could be after exiting the stylomastoid foramen or near the parotid, or it could be an idiopathic case.
Now, since you have asked for history of any fever, any rash, any trauma, any history of any tumors, or any history of any systemic diseases like diabetes, you have ruled out the possible causes of facial nerve paralysis in possible ways of history and on your clinical examination. So since you haven't found any particular reason for this patient to have facial nerve palsy, can we label this patient to have an idiopathic lower motor neuron type of facial nerve palsy on the right side? Now that you have diagnosed that this is an idiopathic facial nerve palsy on history and clinical examination, would you like to go further a step in the investigation and find out what is the cause for this idiopathic palsy? I mean, do you want to rule out the other causes of facial nerve palsy?
Ma'am, on investigations, we can go for the nerve function tests or for the topo diagnostic test so as to confirm our examination finding.
What do you mean by topo diagnostic tests?
Ma'am, topo diagnostic, throughout the course of facial nerve, it gives us several branches which perform different functions. So by doing the topo diagnostic tests, we are basically trying to localize the pathology. For example, in the inner ear, as the first genu of the the geniculate ganglion gives off the greater superficial petrosal nerve, which in the end supplies lacrimal gland through the otic ganglion. So lacrimation is a feature which would be stimulated by this particular nerve. So we can do Schirmer's test. If it is positive, then we can strongly say that the facial nerve previous to this region is normal. Similarly, for the action of stapedius muscle, the facial nerve supplies the stapedius muscle in the middle ear. So we can check for the stapedial reflex. If it is intact, then the course of facial nerve till this point is intact. Like we discussed, for chorda tympani nerve, as the taste sensations are intact, we can say that the chorda tympani is intact. Also for chorda tympani, we can do submandibular gland salivary flow test.
Very good. So you've known the branches, which is why you are able to localize the lesion. So the first nerve that comes is your greater superficial petrosal nerve from the first genu. From the second genu, you have the nerve to stapedius. The vertical segment gives rise to chorda tympani, and just before the exit from the stylomastoid foramen, you have branches going to the submandibular and the sublingual salivary gland. So the respective function of each of these branches is tested, and if any of these function is impaired, then we know that at that point the facial nerve is not functioning. Before that it is functional, but beyond that it is not functional. So if we are able to localize and identify where exactly is the pathology by doing a Schirmer's test, acoustic reflex test, or a taste sensation, or a salivary flow secretion test, then we will be able to identify exactly at what level is the facial nerve affected, or there is a lesion of the facial nerve. So this way of localizing the lesion by clinical examination is called as topo diagnosis. Okay, can you explain me certain electrophysiological tests that you know for facial nerve functioning?
Ma'am, we can do an electroneuronography or electromyography.
What is electroneuronography? In brief, you tell me, I will be explaining it to you.
Ma'am, electroneuronography is basically stimulating the facial nerve and checking for the muscular action on both the sides and comparing. So if there is a deficit if there is a deficit of more than 90%, we could say that the facial nerve function is not improving, or we can prognosticate accordingly. Whereas an electromyography is directly measuring the action potential of the muscle itself, which also help us to decide whether an intervention is needed or not, or the prognostication further that could be done.
Very good. So electroneuronography is a procedure or an electrophysiological test where you are stimulating the facial nerve and recording the response from the facial muscles. So you are stimulating the facial nerve not just on the paralyzed side but also on the normal side. So for example, if I have, say now we're talking of a patient who has a right side facial nerve palsy. I stimulate the right-sided facial nerve, maybe at the stylomastoid foramen, or I can stimulate at the tragal pointer, which are common landmarks which we use. So once we stimulate the nerve, we will get a response in the form of contraction of the muscles on that side. So when the muscles contract, there is a certain amount of compound muscle action potential that is generated in the muscle as a result of contraction. So the electrode that is placed in the muscle receives that potential and tells us how much is the action potential happening at the level of muscle. So you compare the paralyzed side with that of the normal side. So when I stimulated the right side, say I got a compound muscle action potential of 10 in the muscle of the right side. And when I stimulated the left side, I got a compound muscle action potential of 100 on left side. What does that mean? Is there a 90% reduction in the response as compared to the left side? So this means that more than 90% of the neurons have got degenerated. So when we see that there is a 90% degeneration, will we expect that the nerve will regenerate, or should we take an intervention ahead and try to improve the facial nerve functioning?
It is unlikely that the regeneration would occur, so we should go for an intervention.
Yes. So when there is more than 90% degeneration, there is no point in waiting any further for any wait and watch thing and to observe if it will recover spontaneously. In such situation, there is no role of wait and watch or any medical therapy. In such situation, it indicates that you have to either decompress the facial nerve if there is an edema over the facial nerve, or you may, if there is a trauma causing resection of the facial nerve, then you will have to go and anastomose the facial nerve. If there is no cause identified, then you may have to reanimate the facial nerve. You may have to do a transposition graft. So you, depending upon where exactly is the lesion and the type of lesion, partial, complete resection, no resection, there is only edema, you're going to determine your surgical intervention. But when there is more than 90% degeneration, it indicates that you should be proactive in going ahead for a surgery. Now, what is electromyography? Electromyography is a test which measures the electrical potentials in the muscle at a resting state, and when the contraction of the muscle happens when the patient is asked to produce a movement like a smile or to blow the cheek, etc. So at rest, what are the potentials you see, and when a muscle is made to act, what are the potentials you see? So typically there are many potentials that are seen, but the two important potentials that are necessary for us to understand is presence of polyphasic potentials or fibrillation potentials. So polyphasic potentials usually indicate signs of recovery, and usually if you see polyphasic potentials, it's still okay to wait and watch and give steroidal therapy or antiviral therapy or any forms of medical therapy that could help in improving the functioning of the facial nerve. But if you say fibrillation potentials indicate that the nerve is degenerating and you have no other option but to go for any further surgical intervention that is needed. So electroneuronography and electromyography help us in identifying the amount of nerve that is functional and that is degenerated, and helps us in identifying when we can go for medical therapy and when we need to go for surgical intervention. So when we say a patient with facial nerve palsy, we will always first and foremost wait for at least 4 to 7 days and try and give medical therapy. But if the patient is not recovering and if there is a partial recovery with medical therapy, that is when we will further put the patient forward for electroneuronography or electromyography. So now you diagnose the patient as an idiopathic facial nerve palsy, lower motor neuron type on the right side with a Haus-Brackmann of grade 4, and you are probably associating it as a viral pathology. So what will be your treatment, or how will you manage this patient in terms of treatment?
Ma'am, first of all, supportive management is first. Like, I'll reassure the patient that it might get better on itself, and with the medications, I would provide for eye care as the patient is having difficulty in closure of eyes. For the medical treatment, we usually give steroids of 1 milligram per kg per day for about 5 days and assess the response. If the response is, if the condition has got better, we can taper the steroids over the next 5 days. If it does not, we can continue for 10 more days and then reassess and then taper in the next 5 days, giving a total of 20 days of steroids. If the patient does not show any improvement, then we can go for the electrophysiological testing, on the basis of which we can decide whether an intervention is needed or not. If there is no recovery, we can go for an intervention, but if a partial recovery or an improvement could be seen on the test sequentially, we can wait for further betterment to occur.
Yeah. Very correctly said. So can you tell me which steroid is the drug of choice that you would like to give for an idiopathic facial palsy?
And prednisolone is given most commonly.
Okay, fine. So can you tell me what are the other viruses that can cause facial nerve palsy?
Ma'am, viruses such as herpes zoster or even mumps.
So which viruses are associated in the causation of idiopathic facial palsy?
Ma'am, it could be because of herpes simplex or herpes zoster or even Epstein-Barr virus.
Okay. Do you want to add antivirals in the treatment protocol of your patient?
Generally, antivirals are not given.
So antivirals may be given if you see an associated rash like a herpes zoster oticus can present to you with vesicles in the area of distribution of the facial nerve, or if there is an associated fever or a fever has led to a facial nerve paralysis. So if there are symptoms or in your history or on your clinical examination you find certain clinical features that are appreciative to you of probable viral infection, then you may add antivirals. Okay, so now let us quickly talk about the different surgical therapies that are available for the treatment of facial nerve palsy.
Ma'am, we can go for if there is a compression of the facial nerve, we can go for a decompression surgery. Or if the cause of the facial nerve palsy is any trauma or the severing of the facial nerve, we could go for a graft replacement in between.
Okay, so in brief, if we have to decide about the treatment protocol, the first and foremost, most often in idiopathic facial nerve palsy, we assume it's because of the edema that's compressing on the facial nerve. So it's imperative that you open the nerve sheath that is overlying the neuron so that the nerves get space to expand and there is relief of compression on the nerve. So that is called as decompression. That is done usually if you're suspecting an idiopathic palsy or if you're suspecting edema on the facial nerve. Now, a facial nerve palsy commonly can occur because of trauma as well. It can be a direct trauma, it can be because of surgical trauma when you're doing a mastoid surgery or a middle ear surgery. So, if it is because of trauma and if the cut ends are close together to each other, you can get them and anastomose it, which is nerve anastomosis. But if the cut ends are far away, you cannot pull the nerve together and anastomose it. So in such a situation, you will have to take a nerve graft and interpose between the cut ends of the nerve which are lying far away. So this is called as cable grafting. So cable grafting is using another nerve like a sural nerve or a greater auricular nerve in between the two cut ends of the facial nerve to help in conduction of the impulses. Now, facial nerve palsy can happen post-surgery. Say for example, you've talked about mastoid surgery, middle ear surgery. Even if you're doing a vestibular schwannoma surgery, acoustic neuroma surgery or a facial nerve schwannoma surgery by itself, then also you could have a facial nerve palsy as a side effect or a complication of that surgery. In such situation, again depending upon the distance between the cut ends of the nerve, you will decide whether you want to do an anastomosis or you want to do a cable grafting. Now, certain times you will not have any of this available and you may have a complete facial nerve paralysis. So in a complete facial nerve paralysis, you can use a hypoglossal facial nerve anastomosis as well, where you will redirect the fibers of the hypoglossal nerve through the facial nerve to help supply the facial muscles. So that is called as the hypoglossal facial nerve anastomosis. And in rare situation when there is a bilateral facial nerve palsy and you have nothing to do, then you're just going to do rehabilitation surgeries in the form of gold implants which are placed in the upper eyelid through which the patient can mechanically close the eyes so that there is no exposure keratitis or corneal ulcerations. You can give the patient any other synthetic surgeries because of there will be drooping of the angle of the mouth. So certain implants or Botox injections may be given to these patients. So basically surgeries are either decompressive surgeries or anastomotic surgeries for a facial nerve. Now, you mentioned about trauma to the facial nerve, Riya. So, when there is a trauma to the facial nerve, there are fractures of the temporal bone that can cause facial nerve palsy. So, can you tell me which fractures of the temporal bone cause more facial nerve palsy? So, there are two types of temporal bone fractures that can be associated with facial nerve palsy. So, can you tell me which type of fracture is having a higher risk of developing into a facial nerve palsy?
Ma'am, there are two types of temporal bone fractures, longitudinal and transverse. Transverse fractures are more commonly associated with facial nerve injury.
Very good. So, longitudinal fractures are those fractures which run parallel to the long axis of the petrous part of the temporal bone, whereas transverse fractures are those fractures which are perpendicular to the long axis of the petrous bone. So since the facial nerve traverses through the entire petrous bone and then goes into the tympanic bone, anywhere in the petrous bone, whether it is when there is a transverse fracture, there is a very high risk for the facial nerve to get involved. So transverse fractures of the temporal bone have a very high risk of facial nerve injury. Now, when we say that there is a parotid lesion, can it cause a facial nerve palsy?
Yes, ma'am.
Now, if I say that there is a patient who is having a parotid tumor and is having facial nerve palsy, what does that imply to you? Superficial tumor that is involving the deep lobe, that is why it is causing the facial nerve involvement.
Ma'am, there's a superficial tumor involving the deep lobe that is causing the facial nerve palsy.
Yes, so when there is a parotid tumor that is causing facial nerve palsy, it usually indicates that the tumor is not just limited to the superficial lobe of the parotid, it is also going into the deep lobe or infiltrating in the deep lobe, which is why the facial nerve is involved. The facial nerve lies between the superficial and deep lobe, so indication of deep lobe involvement is the presence of facial nerve palsy. So in such situation, only a superficial parotidectomy will not suffice and a total parotidectomy has to be done for this patient. Okay. So now we've discussed on various causes of facial nerve palsy. We've identified the course of the facial nerve. We've learnt about the branches of the facial nerve. We've learnt about topodiagnosis. We've learnt about investigations that we do for facial nerve, about the electrophysiological test and the treatment. So with this, I think the entire facial nerve clinical scenario case is complete, and I hope the learners have found some value in this session that we have discussed so far. Riya, do you have anything that you would like to discuss any further? With this, I'd like to complete the case discussion, and I hope you all enjoyed this, and I will see you all again. Until next time, take care and bye-bye.
Thank you, ma'am.